Hi. In this lecture, we are going to learn about long-term regulation of blood pressure. In the long-term regulation of blood pressure, kidney function is more important than the nervous system. So today our subject is role of the kidneys in long-term control of arterial pressure and in hypertension. Integrated system for arterial pressure regulation. First, our aims, the student will be able to describe the pressure natriuresis and pressure diuresis, describe how renal output of salt and water is balanced with their intake under steady state conditions. The student will be able to explain the renal body fluid feedback mechanism demonstrating a near infinite feedback gain in the long-term blood pressure. List the two primary determinants of the long-term arterial pressure. Explain why increased total peripheral vascular resistance does not elevate the long-term arterial pressure, but fluid intake or renal function does not change. And describe how increased fluid volume can elevate arterial pressure if vascular capacity does not increase. Tell the blood pressure values accepted as hypertension and list the reasons that shortens lifespan of the patients with hypertension. The student will be able to describe the changes in circulatory function during development of volume-loaded hypertension. List the components of the renin-angiotensin system and explain the role of angiotensin II in the regulation of arterial pressure. Explain the importance of the rapidity and intensity of the vasoconstrictor pressure response to the renin-angiotensin system in hypovolemia. The student will be able to tell the effects of angiotensin II that cause renal retention of salt and water, which are important in the long-term control of arterial pressure. Explain how renin-angiotensin system helps to maintain normal arterial pressure during wide variations in salt intake. Explain how does excessive angiotensin II formation cause hypertension. And the student will be able to explain how constriction of the renal arteries causes hypertension, known as one kidney gallbladder hypertension model. Describe the similarity of the coarctation of the aorta causing hypertension with characteristics of one kidney gallbladder hypertension model. Explain how patchy ischemia of one or both kidneys can also cause hypertension. Define toxemia of pregnancy, also known as preeclampsia with hypertension. And finally, the student will be able to list the possible reasons of primary or essential hypertension. And the student will be able to list the order of the mechanisms taking part in the regulation of blood pressure, taking part in the restoration of normal blood volume and pressure in patients with hypovolemia. Describe the nervous system reflexes, rapidly acting blood pressure control mechanisms. List the intermediate blood pressure control mechanisms that act after several minutes. And the student will be able to explain why long-term arterial pressure regulation involves the renal body fluid feedback mechanism. Okay, after these learning objectives, now renal body fluid system for arterial pressure control. Short-term control of arterial pressure by the sympathetic nervous system occurs mainly through the changes in vascular resistance and capacitance and cardiac pumping ability. However, the body also has powerful mechanisms for long-term blood pressure regulation that are closely linked to control of body fluid volume by the kidneys, a mechanism known as renal body fluid feedback system. When arterial pressure rises too high, the kidneys excrete increased quantities of sodium and water because of pressure natriuresis and pressure diuresis respectively. As a result of the increased renal excretion, the extracellular fluid volume and blood volume both decrease until blood pressure returns to normal and the kidneys excrete normal amounts of sodium and water. Conversely, when the arterial pressure falls too low, renal sodium levels and water excretion will be reduced over a period of hours to days. If the person drinks enough water and eats enough salt to increase the blood volume, the arterial pressure returns to its previous level. This mechanism for blood pressure control is slow to act, sometimes requiring several days, a week, or longer to reach equilibrium. Therefore, it is not of major importance in the acute control of arterial pressure. However, it is by far the most potent of all long-term arterial pressure controllers. An experiment demonstrating the renal body fluid system for arterial pressure control. Figure 19.2 shows the results of an experiment in dogs in which all the nervous reflex mechanisms for blood pressure control were first blocked. Then, the arterial pressure was suddenly elevated by infusing about 400 milliliters of blood intravenously. Now, let's look at the figure and then I will come back. Okay, here you see in this figure that now the infusion is made here, 400 milliliters of blood, and nervous system is blocked, and then you see the blood pressure goes up from 100 to 200 millimeter mercury or so, and we also see the cardiac output increases, I guess. Okay, it's about 1500 and it increases about 3500 milliliters in a minute, and then as you see also the urine output increases 12 times of normal. So let's go back. Note the rapid increase in cardiac output to about double normal and increase in mean arterial pressure to 205 mm mercury from 115 to 205. Shown by the middle curve is the effect of this increased arterial pressure on urine output, which increased 12 times. Along with this tremendous loss of fluid in the urine, both cardiac output and arterial pressure returned to normal during the subsequent hour. Thus, one sees an extreme capability of the kidneys to eliminate fluid volume from the body in response to high arterial pressure, and in so doing to return the arterial pressure back to normal. Renal output of salt and water is balanced with the intake of salt and water under steady-state conditions. Figure 19.1 shows the effect of various arterial pressures on urine volume output by an isolated kidney, demonstrating marked increases in the output of volume, known as pressure diuresis, and sodium, known as pressure natriuresis, as arterial pressure rises. As long as the arterial pressure is above the normal equilibrium point, renal output exceeds intake of salt and water, resulting in a progressive decline in the extracellular fluid volume, and also this means decreased intravascular fluid volume, blood volume. So here you see that the mean arterial pressure is 100 mm mercury. Okay, and this is the intake of water and salt. If blood pressure goes up, then output of salt and water will be increased so that blood pressure will return to normal. If it goes down, this time the output will go down, and then blood volume and blood pressure will return to normal again. Okay. Conversely, if blood pressure falls below the equilibrium point, renal output of water and salt is lower than intake, resulting in a progressive increase in extracellular fluid volume. The only point on the curve at which a balance between renal output and intake of salt and water can occur is at the normal arterial pressure, meaning the equilibrium point. Renal body fluid feedback mechanism demonstrates a near infinite feedback gain in long-term blood pressure control. To illustrate why the renal body fluid feedback mechanism demonstrates nearly infinite gain in controlling blood pressure, let us assume that the arterial pressure rises to 150 mm mercury. At this level, renal output of water and salt is about 3 times more than intake. The body loses fluid, blood volume decreases, and the arterial pressure decreases. Furthermore, this loss of fluid does not cease until the arterial pressure decreases to the equilibrium point. Okay, so this one, when the pressure increases, then as you see, uh, it will go to the equilibrium point again if blood pressure goes up, and then excretion of water and salt will be increased, and then blood pressure will return to the normal value again. Conversely, if blood pressure falls below the equilibrium point, the kidneys decrease salt and water excretion to a level below intake, causing accumulation of fluid and blood volume until the arterial pressure returns to the equilibrium point. Because there is little or no remaining error in arterial pressure after full correction, this feedback system has nearly infinite gain. Now to two primary determinants of the long-term arterial pressure. As shown in figure 19.1, one can see that two factors determine long-term arterial pressure. The first one, renal output curve for salt and water, and the second one, the level of salt and water intake. As long as these two factors remain constant, the arterial pressure also remains exactly at the normal level of 100 mm mercury. For arterial pressure to deviate from the normal level for long periods, one of these two factors must be altered. In curve B of figure 19.1, an abnormality of the kidney has caused the renal output curve to shift 50 mm mercury toward higher blood pressure. This shift results in a new equilibrium point, and the arterial pressure follows to this new pressure level within a few days. Although greater salt and water intake can theoretically elevate arterial pressure, the body has multiple neurohumoral mechanisms that protect against large increases in arterial pressure when salt and water intake is elevated. This protection against large increases in arterial pressure is accomplished mainly by decreasing the formation of angiotensin II and aldosterone, which increases the ability of the kidneys to excrete salt and water and results in a steep renal output curve. Therefore, the chronic renal output curve is much steeper than the acute curve in figure 19.1, and in most persons large increases in salt and water output can be accomplished with minimal increases in arterial pressure. Okay, here you see now it is elevated. Okay, then this output of salt and water will be increased 4 times, and then blood pressure will be returned to the normal values again. Okay, so in the B, by increasing the level of salt and water intake in here, and then in A, by shifting renal output in the right hand direction toward the higher pressure level. So this shows if intake increases, then the pressure rises. Okay, and then this will cause an inhibition or formation of renin, and the renin angiotensin system will be inactivated. so that angiotensin 2 level will go down and aldosterone level will go down, so sodium will not be reabsorbed in the kidney tubules, and blood vessels will not be constricted, so this will cause vasodilation. Vasodilation and sodium excretion altogether will normalize the blood pressure again to normal values. Okay. Here you see the effect of chronic and acute renal output curves. As you see, acute high intake increases the blood pressure slowly, whereas chronic increases in salt and water cannot increase the mean arterial pressure much, because this excess amount of salt and water will be excreted in chronic condition. If there is a problem with the kidney, there is a kidney disease, impaired kidney function, the steepness of the renal output curve will be reduced, so it will be similar to the acute curve, and then it can cause an increase in the blood pressure, as you see. So increased total peripheral vascular resistance does not elevate the long-term arterial pressure if fluid intake or renal function does not change. When total peripheral vascular resistance is acutely increased, arterial pressure increases almost immediately. So this means vasoconstriction of the peripheral blood vessels or atherosclerosis. Okay. However, if vascular resistance of the kidneys is not increased and they continue to function normally, the acute rise in arterial pressure is not maintained. The reason for this phenomenon is that increasing resistance everywhere in the body except in the kidneys does not change the equilibrium point for blood pressure as dictated by the renal output curve. With increased peripheral resistance and arterial pressure, the kidneys undergo pressure diuresis and pressure natriuresis, causing loss of salt and water from the body. This loss continues until the arterial pressure returns to the normal equilibrium point. Okay, so to the normal equilibrium point, it will come to the normal equilibrium point as you see here, and excess water and sodium will be excreted when there is an increase in total peripheral resistance. This will cause an increase in blood pressure and then will cause excretion of excess water and sodium in the urine, output of excess amount of sodium and water will be excreted, and then blood volume will return to the lower values, and blood pressure also will return to the normal values. Okay. In many cases, when total peripheral resistance increases, renal vascular resistance also increases, which causes hypertension by shifting the renal function curve to higher blood pressures. When this shift occurs, it is the increase in renal vascular resistance, not the increase in total peripheral resistance, that causes the long-term increase in arterial pressure. Okay, in this graph, you see different clinical conditions in which total peripheral resistance is affected. Normally, when arterial pressure is 100 mm mercury, and this is the total peripheral resistance, and the pressure and the cardiac output is shown here. The cardiac output curve can be followed here. Okay. So the relations of total peripheral resistance to the long-term levels of arterial pressure and cardiac output in different clinical conditions. In these conditions, the kidneys were functioning normally. Note that the change in whole body total peripheral resistance caused equal and opposite changes in cardiac output, but in all cases had no effect on arterial pressure. Okay. All right, remove of 4 limbs, then blood pressure goes down, hypothyroidism, metabolism goes down, The total peripheral resistance increases quite much. Okay, in Paget disease or pulmonary disease, anemia, hyperthyroidism, arteriovenous shunt, and very total peripheral resistance goes down, and then cardiac output goes up, so that keeps blood pressure within normal values. Okay, so increased fluid volume can elevate arterial pressure if vascular capacity does not increase. The following sequential events link increased extracellular fluid volume and increased arterial pressure. First, increased extracellular fluid volume and increased blood volume. And second, increased mean circulatory filling pressure. And then this will cause increased venous return of blood to the heart. And then if venous return increases, it increases the cardiac output. When the cardiac output goes up, then it increases the arterial pressure. So increased cardiac output by itself tends to elevate the arterial pressure. However, increased cardiac output also causes excess blood flow in many of the tissues of the body that respond by vasoconstriction, which tends to return the blood flow toward normal. This phenomenon is called autoregulation and tends to raise total peripheral resistance. With higher extracellular fluid volume, there is an initial rise in cardiac output and a rise in tissue blood flow, but after several days, total peripheral resistance begins to increase because of autoregulation, and cardiac output usually returns to normal. So here you see the events. Increased extracellular fluid volume will cause an increase in blood volume, so mean circulatory filling pressure goes up, and then venous return will go up, and then cardiac output will be increased. So the cardiac output increases the arterial pressure directly, and also by autoregulation, uh, total peripheral resistance will be increased, and then it will also cause an increase in arterial pressure. So when arterial pressure goes up, pressure diuresis and natriuresis will occur, so urine output will be increased, the excess volume will be lost, so that blood volume will return to normal, and everything will be decreased, and then blood pressure will be decreased, will be normalized. If increases in extracellular fluid volume and blood volume are associated with increased vascular capacity, arterial pressure may not increase. For example, persons with liver cirrhosis often have a large increase in extracellular fluid volume resulting from decreased liver synthesis of plasma proteins and subsequent leakage of fluid from the blood into the tissues. Fibrous liver tissue may also impede prevent blood flow through the liver, causing high pressures in the portal circulation in the abdominal veins, distending the veins and increasing vascular capacity. Likewise, persons with large varicose veins have increased vascular capacity. In these instances, the kidneys actually retain salt and water, and increases in extracellular fluid volume and blood volume serve as a compensatory response that helps prevent blood pressure from decreasing to low values. Now, hypertension. Normal systolic and diastolic arterial pressures are about 120 to 80 mm mercury, with a mean arterial pressure of 93 mm mercury under resting conditions in an adult. Hypertension is said to occur when the diastolic pressure is higher than 90 mm mercury, or the systolic pressure is higher than 135 or 140 mm mercury. Even moderate elevation of arterial pressure leads to shortened life expectancy, at least in three ways. First, excessive workload on the heart leads to early heart failure and coronary artery disease, congestive heart disease, or both, often causing death as a result of heart attack. And secondly, high blood pressure often leads to rupture of a major blood vessel in the brain, or hypertrophy and eventual obstruction of a cerebral blood vessel. Either occurrence leads to cerebral ischemia and death of a portion of the brain, a condition called stroke. And thirdly, high blood pressure often causes damage to the kidneys and can eventually lead to kidney failure. So these are the complications of hypertension in the long term, decreasing the lifespan of patients with hypertension, heart attack, stroke in the brain, blood vessels rupturing, and kidney damage in the long term. Glomerulosclerosis and the kidney failure can be developed. That's why hypertension is an enemy that you can't see it. Okay. Now, hypertension can occur in a number of ways. With all types of hypertension studied thus far, however, a shift of the renal output curve toward higher blood pressures has occurred. Lessons learned from a type of hypertension called volume loading hypertension have been crucial to understanding the role of renal body fluid feedback mechanism for arterial pressure regulation. Now, changes in circulatory function during development of volume loading hypertension. In experiments in which the kidney mass of animals has been surgically reduced to about 30% of normal, an increase in the salt and water intake causes marked hypertension. Although reduction of the functional kidney mass alone does not cause significant hypertension, it reduces the ability of the kidney to excrete a large load of salt and water effectively. When salt and water intake are increased and kidney function is impaired, the following sequence of events occurs in the body. Extracellular fluid volume and blood volume are expanded. Increased blood volume increases the mean circulatory filling pressure, venous return, and cardiac output. Increased cardiac output raises the arterial pressure. And during the first day after increased salt and water intake, a decrease in total peripheral resistance occurs that is caused mainly by the baroreceptor reflexes, which attempt to prevent the rise in blood pressure. After several days, cardiac output gradually returns toward normal as a result of long-term blood flow autoregulation, which simultaneously causes a secondary increase in total peripheral resistance. As arterial pressure increases, the kidneys excrete excess volume of fluid through the pressure diuresis and pressure natriuresis, and the balance between intake and renal output of salt and water is re-established. This sequence illustrates how an initial abnormality of kidney function and excess salt and water intake can cause hypertension. It also shows that the volume loading aspects of hypertension may not be apparent after kidneys have had sufficient time to re-establish sodium and water balance and after the autoregulatory mechanisms have caused an increase in total peripheral resistance. Two clinical examples of volume loading hypertension are as follows. First one, volume loading hypertension can occur in patients who have no kidneys and whose kidney function is being maintained with the use of artificial kidney. If blood volume of a patient whose kidney function is being maintained with the use of an artificial kidney is not regulated at the normal level and is allowed to increase, hypertension develops in almost exactly the same way as previously discussed. And second example, excessive secretion of aldosterone causes volume loading hypertension. Occasionally, a tumor of the adrenal glands causes excessive secretion of aldosterone, which increases reabsorption of salt and water by the tubules of the kidneys. This process reduces urine output, causing an increase in extracellular fluid volume and initiating the same sequence described previously for volume loading hypertension. Now, the renin-angiotensin system and its role in arterial pressure control. In addition to its capability of controlling arterial pressure through changes in extracellular fluid volume, the kidneys control pressure through use of the renin-angiotensin system. When the arterial pressure falls too low, the kidneys release a protein enzyme called renin that activates the renin-angiotensin system and helps increase the arterial pressure in several ways, thus helping to correct for the initial decrease in blood pressure. What are the components of the renin-angiotensin system and its role of angiotensin II and the role of angiotensin II in the regulation of arterial pressure? The renin-angiotensin system acts in the following manner for acute blood pressure control. A decrease in arterial pressure stimulates renin secretion from the juxtaglomerular cells of the kidney into the blood. Renin catalyzes the conversion of renin substrate or angiotensinogen synthesized in the liver to release a 10 amino acid peptide, angiotensin I. Angiotensin I is converted to angiotensin II by the action of a converting enzyme present in the endothelium of vessels throughout the body, especially in the lungs and the kidneys. And angiotensin II, primary active component of renin-angiotensin system, is a potent vasoconstrictor and helps raise the arterial pressure. Angiotensin II persists in the blood until it is rapidly inactivated by multiple blood and tissue enzymes collectively called angiotensinases. In this figure, you see a nephron. Here is the glomerular capillary and afferent and efferent arterioles of it. So the distal tubule passes through or between afferent and efferent arterioles of the glomerulus. So this section, the cells in the distal tubule are special cells. They are called macula densa cells. They are sensitive to the volume of the glomerular filtration, glomerular ultrafiltrate arriving to this distal tubule section, and they detect the volume decrease and also sodium concentration. If volume goes down and sodium goes down, these macula densa cells will detect and will inform the afferent arterial cells of glomerulus. So as you see this section, you see this is the afferent arterial cells and there's macula densa cells next to the afferent arterial and efferent arterial cells. So when glomerular ultrafiltrate goes down or sodium concentration in the macula densa in the distal tubule is decreased, then these macula densa cells will detect and will inform nearby juxtaglomerular cells in afferent arteriole, and then they secrete renin into the blood, and then renin-angiotensin system will be activated. Okay, so renin will convert angiotensinogen to angiotensin I. Angiotensinogen is synthesized in the liver. Angiotensin I it will be converted to angiotensin II by angiotensin converting enzyme present in the lung capillary endothelium. And then angiotensin II is the most potent hormone, we can say, causing vasoconstriction, one of the most potent substances causing systemic vasoconstriction to increase blood pressure, stimulating surrenal cortex to release excess amount of aldosterone, and aldosterone increases sodium reabsorption and water reabsorption in addition to sodium, so that increase in the blood volume. Okay, also affects the hypothalamus, so the person will feel thirsty and will drink more water. Altogether, angiotensin system will try to increase the blood pressure back to normal values when it goes down. Okay, decreased arterial pressure causes the renin secretion from the kidneys, and then renin will convert angiotensinogen to angiotensin I, and converting enzyme, as I said, it is present in the lung capillary endothelium, and then it will be converted to angiotensin 2, and angiotensin 2 is a systemic vasoconstrictor substance, and it also increases aldosterone secretion from the surrenal cortex, and other aldosterone will increase sodium and water reabsorption. So as you see, they all contribute to increased arterial pressure. When arterial pressure returns to normal, and angiotensin 2 will be inactivated by the enzymes present in different tissues and blood, angiotensinase. So angiotensin 2 has two principal effects that can elevate the arterial pressure. First one is angiotensin 2 constricts arterioles and veins throughout the body, thereby increasing total peripheral resistance and decreasing vascular capacity, which promotes increased venous return to the heart. These effects are important for preventing excessive reductions in blood pressure during acute circumstances such as hemorrhage. And secondly, angiotensin 2 decreases salt and water excretion by the kidneys. This action slowly increases extracellular fluid volume, which increases arterial pressure over a period of hours and days. Now, rapidity and intensity of vasoconstrictor pressure response to the renin-angiotensin system. Figure 1911 shows a typical experiment demonstrating the effect of hemorrhage on the arterial pressure under two separate conditions. First, with the renin-angiotensin system functioning, and the second, without system functioning. So this system was interrupted by a renin-blocking antibody. So let's see the figure. Here you see the hemorrhage is made here in the dog, I guess, and arterial pressure goes down from 100 to 50 millimeter mercury. If renin-angiotensin system is not working, is not functioning, is blocked by an antibody. So as you see, within minutes, you can't see normalized or increased blood pressure in response to hemorrhage. Okay. On the other hand, when renin-angiotensin system is intact and working properly, as you see, within 10 to 20 minutes period of time, blood pressure goes up, although it's not fully arrive in the previous blood pressure. It increases quite much. Instead of 100 millimeter mercury, it increases to 75. So it is enough to keep the animal alive. Otherwise, very low blood pressure can cause shock table, and shock table can be progressive situation causing death of the animal with the positive feedback mechanisms. Okay. Alright, note that the hemorrhage after hemorrhage enough to cause acute decrease in arterial pressure to 50 mm mercury, the arterial pressure rose back to 83 mm mercury when the renin-angiotensin system was functional. Conversely, it rose to only 60 mm mercury when renin-angiotensin system was blocked. This shows that the renin-angiotensin system is powerful enough to return the arterial pressure at least halfway back to the normal within a few minutes after severe hemorrhage. Therefore, sometimes it can be of life-saving service to the body, especially in circulatory shock. Note also that the renin-angiotensin vasoconstrictor system requires about 20 minutes to become fully active. Therefore, it is somewhat slower to act for blood pressure control than are the nervous reflexes and the sympathetic norepinephrine and epinephrine system. They cause immediate vasoconstriction, and they cause increased contractility of the heart. So they immediately try to increase the blood pressure after hemorrhage. Effects of angiotensin 2 that cause renal retention of salt and water are especially important for long-term control of arterial pressure. Angiotensin 2 causes salt and water retention by the kidneys in two ways. Angiotensin acts directly on the kidneys to cause salt and water retention. Angiotensin 2 constricts efferent arterioles, which diminishes blood flow through the peritubular capillaries, increasing reabsorption from the tubules. In addition, angiotensin II directly stimulates the epithelial cells of the renal tubules to increase the reabsorption of sodium and water. And angiotensin II stimulates the adrenal glands to secrete aldosterone, and aldosterone increases salt and water reabsorption by the epithelial cells of the renal tubule. Renin-angiotensin system helps maintain normal arterial pressure during wide variations in salt intake. One of the most important functions of the renin-angiotensin system is to allow a person to ingest either a very small or very large amount of salt without causing great changes in either extracellular fluid volume or arterial pressure. For example, when salt intake is increased, there is a tendency for extracellular fluid volume and arterial pressure to increase. Increased salt intake also decreases renin secretion and angiotensin II formation, which in turn decreases renal tubular salt and water reabsorption. Reduced tubular reabsorption allows the person to excrete extra amounts of salt and water with minimal increases in extracellular fluid volume, so the arterial pressure. When salt intake is decreased below normals, just opposite effect will occur. As long as the renin-angiotensin system is fully operative, salt intake can be as low as 10% of normal or as high as 10 times of normal with only a few millimeters mercury change in arterial pressure. On the other hand, when the renin-angiotensin system is blocked, the same changes in salt intake can cause large variations in blood pressure, often as much as 50 millimeter mercury. Now, excessive angiotensin II formation causes hypertension. So occasionally, a renin-secreting tumor of the juxtaglomerular cells occurs and causes excessive angiotensin II formation, which almost invariably leads to severe hypertension. One effect of angiotensin II is to increase total peripheral resistance, which is the primary cause of the rapid rise in blood pressure that occurs when angiotensin II levels are suddenly elevated. The long-term increase in blood pressure associated with excessive angiotensin II formation is due mainly to the various actions of angiotensin II that cause renal salt and water retention. Now, impaired renal circulation causes hypertension, any condition that greatly reduces the ability of the kidneys to excrete salt and water can cause hypertension. Types of renal circulatory dysfunction that can cause severe hypertension include renal vascular damage, such as occurs with stenosis of the renal arteries. Secondly, constriction of the afferent arterioles. And thirdly, increased resistance to fluid filtration through the glomerular membrane. That is to say, decreased glomerular capillary filtration coefficient. Each of these factors reduces the ability of the kidney to form glomerular filtrate, which in turn causes salt and water retention, as well as increased blood volume and increased arterial pressure. The rise in arterial pressure then helps return the glomerular filtration rate toward normal and reduces tubular reabsorption, which permits the kidneys to excrete normal amounts of salt and water despite the vascular disorders. Now, constriction of the renal arteries causing hypertension. When one kidney is removed and a constrictor is placed on the renal artery of the remaining kidney, the immediate effect is greatly reduced pressure in the renal artery beyond the constriction. Within a few minutes, systemic arterial pressure begins to rise, and it continues to rise for several days until the renal arterial pressure beyond the constriction has returned almost to normal values. Hypertension produced in this way is called one-kidney gallbladder hypertension, in honor of Henry Goldblatt, who first described the features of hypertension caused by this method in experimental animals. So in this figure, one of the kidney is removed and then one kidney is left, and then the renal artery is clamped, narrowed, and as you see here, constricted. And then what happens to the pressure? you can see the pressure goes up, and then also you can see the renin secretion goes up. Okay. uh, when renin goes up, then it causes hypertension. When constriction is released, as you see, blood pressure also start to go down, and then renin secretion also will be normalized, will be decreased. Okay. So the effect of placing a constricting clamp on the renal artery of one kidney after the other kidney has been removed. Note the changes in systemic arterial pressure, renal artery pressure distal to the clamp, and the rate of renin secretion. Resulting hypertension is called one kidney gallbladder hypertension. Rapid rise in arterial pressure in gallbladder hypertension is caused by activation of renin-angiotensin vasoconstrictor mechanism. Because of poor blood flow through the kidney after a reduction of renal artery pressure, large quantities of renin are secreted, causing increased angiotensin II formation and a rapid rise in blood pressure. A more delayed rise in blood pressure occurring over a period of several days is caused by fluid retention. The fluid retention and expansion of the extracellular fluid volume continue until the arterial pressure has risen sufficiently to return the renal perfusion pressure to almost normal levels. Hypertension also occurs when the artery of one kidney is constricted and the other artery of the other kidney is normal, which is often called two-kidney gallbladder hypertension. The constricted kidney retains salt and water because of decreased arterial pressure in this kidney. The normal kidney retains salt and water because of the renin produced in the ischemic kidney and increase in circulating angiotensin II, which causes opposite kidney to retain salt and water. Also, aldosterone secretion because of both kidneys retain salt and water, and hypertension will be developed. Coarctation of aorta above the renal arteries causes hypertension with characteristics similar to those of one kidney gallbladder hypertension model. Aortic coarctation results in decreased perfusion pressure to both kidneys, stimulating the release of renin and angiotensin II formation, as well as salt and water retention by the kidneys. These changes increase the arterial pressure in the upper part of the body above the coarctation level, thereby helping to return the perfusion pressure of the kidneys toward normal. Now, patchy ischemia of one or both kidneys can also cause hypertension. When ischemia occurs, the characteristics of hypertension are almost identical to those of two-kidney gallbladder hypertension. Patchy ischemic kidney tissue secretes renin, which in turn stimulates formation of angiotensin II, causing even the non-ischemic nephrons to retain salt and water. This type of hypertension is much more common than hypertension caused by constriction of the main renal arteries or coarctation of aorta, especially in older patients with atherosclerosis. Toxemia of pregnancy or preeclampsia is also associated with hypertension, although the precise cause of hypertension in this condition is not completely understood. Many physiologists believe it is due to ischemia of the placenta, so near to the 8 months or 9 months, close to, mother will develop hypertension, proteinuria, and edema. This is called preeclampsia. In this case, placenta can release toxic factors that cause many of the manifestations of this disorder, including endothelial dysfunction, impaired renal pressure diuresis, natriuresis, and hypertension in the mother. Another pathological factor that may cause hypertension in preeclampsia is thickening of the glomerular membranes, perhaps caused by autoimmune process, which reduces the glomerular capillary filtration coefficient and rate of fluid filtration from the glomeruli into the renal tubules. Now, the causes of human primary or essential hypertension are unknown. Approximately 25 to 30% of the adults in industrialized societies have high blood pressure, although the incidence of hypertension is higher among elderly. The precise cause of hypertension is about 90% of these people is unknown, and it is called as primary or essential hypertension. Although the exact causes of primary hypertension are not fully understood, excess weight gain and sedentary lifestyle appear to play a major role. Studies of different populations suggest that excess weight gain and obesity may account for as much as 65 to 75% of the risk of developing primary hypertension. Most patients who are obese or overweight and experience the development of essential hypertension slowly over many years have significant changes in their kidney function. Most importantly, the kidneys cannot excrete adequate quantities of salt and water at normal arterial pressures. Instead, they require a high arterial pressure to maintain a normal balance between the intake and output of salt and water, unless they are treated with drugs that enhance their ability to excrete salt and water at lower blood pressures. Now, the summary of the integrated, multifaceted system for arterial pressure regulation. It is clear that arterial pressure is regulated by several systems, each of which performs a specific function. Some systems are most important for acute regulation of blood pressure and react rapidly within seconds or minutes. On the other hand, others respond over a period of minutes or hours. Some systems provide long-term arterial pressure regulation over days, months, even years. Here you see these systems together in a single graph. Okay, approximate potency of various arterial pressure control mechanisms at different time intervals after the onset of disturbance to the arterial pressure. Note especially the infinite gain of the renal body fluid pressure control mechanisms that occurs after a few weeks' time. All right, now let's say if blood pressure goes down, there is bleeding or something, okay, within seconds you can see the responses. First, baroreceptors will inform the central nervous system, okay, they will fire less frequently, so this is also a stimulation for the brain, and will cause sympathetic activity increase in the nervous system, so that causing vasoconstriction and uh, heart contraction. Heart will contract faster and stronger. Okay. What else? Central nervous system ischemic response if blood pressure goes to very low values. Okay. And chemoreceptors also are sensitive to low blood pressure. And stress relaxation mechanism is very important. What was that? Stress relaxation was, let's say if the blood volume is decreased, there is hemorrhage in this condition. Now volume of blood went down, and smooth muscle cells in the walls of the veins, in the walls of the major arteries will be reorganized, so that the volume of the veins and the arteries will be decreased to adapt to the decreased volume, so that blood pressure will not go to very low values. So this is called stress relaxation. Actually, this is reverse stress relaxation. Okay, when blood is infused, the volume is increased, then the smooth muscle cells will be relaxed, will be reorganized in the relaxed position. This was stress relaxation. If there is blood loss, then in this case there will be just opposite, reverse stress relaxation. So will be decreased, the volume of the blood vessels will be decreased, and then capillary fluid shift, when blood volume goes down due to bleeding or for any reason, interstitial fluid will shift from the interstitium into the blood vessels, so that increasing the blood volume, okay, and returning to the blood pressure to normal values. And the renin-angiotensin system will be activated within minutes, and then it will cause, uh, aldosterone secretion from the surenal cortex, so the aldosterone will cause sodium reabsorption, and then water will follow the sodium reabsorption osmotically, so the aldosterone will take part. And as you see, renal volume pressure control mechanism will take part, so the keeping the blood volume, blood sodium amount normal. So it takes days, months, days, weeks, months, even years. Okay. Now let's see these mechanisms closely. First, nervous system reflexes are rapidly acting blood pressure control mechanisms. The three nervous reflexes that act rapidly within seconds are the baroreceptor feedback mechanism, and the central nervous system ischemic mechanism, and the chemoreceptor mechanism. We have talked about this in our previous lectures. Baroreceptors are sensitive to the blood pressure after 60 millimeter mercury or so. If blood pressure goes up, the frequency of baroreceptor stimuli will be increased. If blood pressure goes down, this time the frequency will go down. So this is also a stimulus for the brain. Chemoreceptor mechanism. Chemoreceptors are sensitive to hypoxia, hypercapnia, and increased hydrogen concentration. On the other hand, they are also sensitive to blood pressure, but they are sensitive to lower blood pressure, okay? About 30 millimeter mercury or so, the chemoreceptors will inform the brain that the blood pressure is so low. Central nervous system ischemic mechanism, it is the last step, last stage that the brain can cause contraction in other vascular beds except heart and the brain. And brain would like to survive, so this is called central nervous system, central nervous ischemic mechanism. These mechanisms are powerful in preventing acute decreases in blood pressure, for example, during severe hemorrhage. They also operate to prevent excessive increases in blood pressure, such as might occur in response to excessive blood transfusion. Now, intermediate blood pressure controlling mechanisms that act after several minutes. Three mechanisms that are important in blood pressure control after several minutes of acute pressure change are renin-angiotensin vasoconstrictor mechanism, stress relaxation of the vasculature, and shift of fluid through the capillary walls in and out of the circulation to readjust the blood volume as needed. We have just talked about them. I think it takes 20 minutes or so for the renin-angiotensin system to take part, and stress relaxation of the vasculature also takes some time. Reverse stress relaxation is seen in hypovolemia, and stress relaxation is seen in transfusion or excess volume of blood. And shift of fluid in hypovolemia, interstitium, from interstitium to the blood. The fluid will enter so that it increases the blood volume and it normalizes the blood pressure. The role of renin-angiotensin vasoconstrictor mechanisms has been described. The stress relaxation mechanism is demonstrated by the following example. When pressure in the blood vessels becomes too high, the vessels become stretched and continue to stretch for a few minutes or hours. As a result, the pressure in the vessels tends to fall back toward normal, so they will be relaxed, okay? Capillary fluid shift mechanisms means that anytime the capillary pressure falls too low, fluid is absorbed from the tissue into the capillaries of the circulation, thereby increasing the blood volume and helping return the blood pressure toward normal. Conversely, when capillary pressure rises too high, fluid is lost out of the circulation, thereby reducing the blood volume and the arterial pressure in turn. Okay. Again, you see the time when which mechanism take part in the regulation of blood pressure, how fast and how slow do they take part in this graph. In the long term, arterial pressure regulation involves the renal body fluid feedback mechanism. Renal body fluid feedback control mechanism takes several hours to show any significant response, but then it operates powerfully to control arterial pressure over days, weeks, and months, as long as the kidney function is unaltered. Disturbances that tend to alter arterial pressure, such as increased total peripheral resistance, have minimal effect on blood pressure over long periods. Factors that alter the ability of the kidneys to excrete salt and water can cause major long-term changes in arterial pressure. This mechanism, if given sufficient time, controls the arterial pressure at a level that provides normal output of salt and water by the kidneys. Many factors can affect the renal body fluid feedback mechanism and therefore long-term blood pressure control. One of the most important factors is the renin-angiotensin system, which allows a person to have very low or very high salt intake with minimal changes in arterial pressure. Thus, arterial pressure control begins with life-saving measures of the nervous reflexes, continues with the sustaining characteristics of the intermediate pressure controls, and finally is stabilized at a long-term pressure level by renal body fluid feedback mechanism. So, in this lecture, we have seen the role of kidneys in the long-term regulation of blood pressure by adjusting salt and water intake and also output. Blood pressure regulation is very critical, very important. This kidney, the role of kidney in the blood pressure regulation is important in medicine, in pediatrics, in internal medicine, in neurology, in anesthesiology, etc. So you better know this subject very well, also in pharmacology in next year, I guess, to understand the antihypertensive drug actions. It's better to grasp the information given in this section, in this lecture. I used shorter the abstract of the Guyton by adding some information from the long text in Guyton. I strongly recommend you to read this chapter when you have spare time. Okay. I tried to give the essential information to you. So if I make a summary, what is left in our mind after this lecture, I think when you take excess salt and water, your volume of blood can temporarily goes up, okay? And then this, if the blood volume goes up, then venous return will go up, cardiac output will be increased, and the blood pressure will be increased, okay? And then this will cause excess sodium and water excretion, okay? Pressure diuresis will occur or pressure natriuresis will occur. So this excess salt and water you intake, your intake will be removed, will be excreted from the body, and your blood volume will return back to normal, okay? But it is not good to take salty food all the time. As far as I know, in the beginning, the blood volume increase is causing hypertension temporarily. This is labile phase of hypertension disease, and if the patient continues to use excessive salt in his or her diet, then this increased blood pressure can increase the total peripheral resistance, can cause atherosclerosis, and then hypertension will be established, okay? And we call it as essential hypertension, although it is essential, actually we knew that it is going to develop, okay? It's not good to use excessive salt in our food. It's better not to do that. And we have talked about the renin-angiotensin system, okay? When glomerular filtration goes down, when sodium concentration in the ultrafiltrate goes down, then the macula densa cells will detect in the distal tubules decreased ultrafiltrate, and then will inform the afferent arteriole cells nearby, and these afferent arteriole cells are called juxtaglomerular cells. They will release renin into the blood, and renin will convert angiotensinogen to angiotensin 1. Angiotensinogen synthesized in the liver, and angiotensin 1 will be converted by angiotensin converting enzyme present in the lung endothelium, lung circulatory system, and then angiotensin 2 will be formed. Angiotensin 2 has a strong vasoconstrictive activity, increasing the blood pressure, and then in addition will stimulate adrenal cortex to release aldosterone, and aldosterone will cause sodium and water reabsorption to increase the blood volume. In addition, angiotensin 2 will cause vasoconstriction in the efferent arteriole of the glomerulus, so that uh, in this way, increasing the glomerular filtration. Okay. It also stimulates the hypothalamus, so that the person will feel thirsty, will drink more water. Altogether, blood pressure, blood volume, blood pressure will be normalized. Okay, this renin-angiotensin system is very important in hemorrhage, in bleeding conditions, to bring the blood pressure back to normal values. Okay, within 20 minutes, it helps quite much. If this system is not functioning, then the shock table can be developed much easily. All right. I think that's enough for this lecture. I hope it is useful. It will be useful for you, and you understand some part of it. Or, of course, uh, if you could, I wish you understood everything in this lecture. Thank you very much for listening.